This project that we are going to present today is an effort that was recognized by the AAMC for an award, a Pioneer Award, which is an award that is for learners, not the kind of award where you're showing off what you already did. It's an award to support a learning and in the mode of learning health systems. The team that we assembled for working on this effort is co-led by Sandi and I, but we had an advisory committee that included representatives from the Healthcare System Innovation, Health Services Research Department, informatics faculty and grad students, primary care providers who are in the field, particularly in the outpatient clinics, trying to do all this work, inpatient hospitalists and radiology specialists, quality experts, pharmacy, the EPIC EMR team, the folks that are building and trying to implement what everyone's asking for, and finally the knowledge management team, the folks who develop Pulse and deal with where do we put all these documents and all the issues related to document control. So this was a very broad group of folks that were pulled together in order to help advise us in this effort. So in this talk, we're going to talk about, focus on some background, talk about the goals and objectives, and then we're going to describe our initial use case. Before you can start talking about things theoretically and thinking about what problems you want to solve, my opinion, and this is what I want all the students, you to take away, you have to dig your heels into some problem and really understand the details. So we dug into the use case of the knee pain care process. Then we articulated 5 threads of work that needed to be done, and we'll talk about the current state and the next steps related to those 5 threads of work, and finally talk about lessons learned. So Sandi's going to talk about the background.
Okay, does that work? Can you hear me? Yeah. Okay, awesome. So many of you know, I think you've heard me talk before, but in case you don't, we're on this path, this lean journey here at University of Utah Healthcare, and we have a culture in which we have to place this proposed solution. And so some of the things we want to look at is, what do our stakeholders need? MOC is maintenance of certification, so our providers have a requirement now to work on quality improvement projects, and so how do we integrate both the attendings and the residents in our QI process? Value engineering, we do QI training for the organization. We have accreditation by DNV, and ISO 9001 certification is up in either December or January. And that requires us to do some special things with document control, which are the right things to do. Also accrediting our residency program is the CLEAR program, and we need to incorporate them as well. And then, of course, the operations goals of the hospitals and clinics, the financial engine. And then we have a value methodology. We have a generalized framework based on Lean Six Sigma. Many of you have seen this equation before. Value is equal to cost plus service, quality plus service over cost. We have value summaries to document our work. We have this amazing tool called VDO, Value Driven Outcomes, that allows us to get to the patient level cost information and also outcomes data for that particular patient. And now we're embarking over the last 24 months on redesigning care for our top 50 medical conditions, among others, but that's the priority for the organization. So we haven't typically used care pathways in this organization. Standard work was not something that we had as a system-wide goal. We're moving towards that in our effort to streamline and standardize our processes and doing the right things for our patients. And so the development of what we initially called a value-driven care process model is really important as these care pathways grow. As we have more and more, we need more standardization. And so we saw the gap, Catherine and I. We had this opportunity to apply for a grant. We saw the gap, and we were feeling pretty good about ourselves because we got the grant. And we were looking over the landscape. It's quite pretty. Lots of work to do. If you're going to hike, a lot of work to do. But we weren't sure at that time what exactly would we mean by value-driven care process here at University of Utah Healthcare? And we got lots of different answers, as you can see. There's pathways and protocols and guidelines and order sets and BPAs and on and on and on. And then reality set in. And we felt like we were dangling over that cliff that we were. You like the Photoshop? It's awesome. Thank you, Catherine, and your daughter. But we gathered ourselves. We're resilient humans, and so we gathered ourselves up, and we started where we should start. Let's define what we mean in this effort by value-driven care process. And our steering committee made very minor tweaks to this. There was a lot of work done, and we'll talk about our student team. They did a great job searching the literature. Value-driven care process is a transdisciplinary, defined, and optimized sequence of tasks by healthcare professionals designed to enhance value delivered to a patient population with an expected clinical course. So when we think about the rest of this presentation and beyond, this is what we mean by those words. So, like I mentioned earlier, value-driven care process is quite a mouthful. VDCP, what does that mean? Nobody seemed to know. So we are ever evolving in this organization, and so this is a University of Utah healthcare thing. Value-driven redesign, process, pathway, populations. And so that's kind of our catch for all of this work that's going on under the lean umbrella. It could be optimizing a business process, it could be redesigning care, and you need a pathway for that. And then we have to start thinking about how we're going to manage populations in the long run, and what does that mean, and what does care around a population look like. So for this particular care pathway project, we looked at the diagnostic phase. So we were looking at chief complaint symptoms versus a diagnosis. We were specifically set in the outpatient setting, because that's where the majority of the few care pathways were. So we have a really amazing organization. We have really talented individuals working here, and they're all hitting the right note. They're hitting their own right note. We didn't have an inventory of care pathways. We didn't have a standardized process to develop them. They didn't look the same. They didn't feel the same. They didn't trigger in the same way for similar types of processes. Where were the approvals? How do we communicate this? We had all kinds of questions. But again, people doing absolutely the right thing for their patient population without a system view. Well, we wanted to do better. We have to do better. We want a symphony. So we wanted to develop some standard work, have coordinated development and implementation, have the same look and feel across the system wherever possible, have it well communicated, have it user tested, evaluated, and then actually monitor and maintain. If we're firing a BPA, do we know it's getting used? If it's not getting used, why? If we are, if we're just producing a document for them for guidance, how do we reference that? And when was the last time it was updated? I'm not showing this slide, but I discovered a 2007 asthma protocol on our site. Has it ever been reviewed? I don't know. Probably, but there's no way to trace that down, and that's the right thing to do for our patients, to make sure that we're using the most up-to-date guidance to treat our patients. And then it's a requirement for DNV. So this was our proposal to AAMC. There were a lot more words attached to this, but develop a standardized and accepted process for creating, implementing, and evaluating value-driven care pathways within an academic health enterprise. That's our scope. And like Catherine mentioned, there are 5 threads of work. There are 5 phases: design, development, implementation, maintenance, and evaluation. And they're not necessarily circular. But that was just an easy representation, right? So future state: standardized, accepted, usable, standard work, analyzing the workflow. What are the implications to Epic? What did the diagrams look like? Where are they housed? What do they fire? Do they fire BPAs? Do you get an order set? Is that fired off a chief complaint or diagnosis? How do you manage all the artifacts? So what does that infrastructure look like for us? We need version control and maintenance, and we have to update those regularly. We need a portal for access and feedback. So if I'm outside of the context of a patient visit and I want to look at knee pain, for example, I need a way to easily find that. If you go on Pulse today and you type in knee pain, you get a whole list of documents you have to sort through. We want it to be easy for the clinicians or whoever's providing the care. Standard methods for monitoring, the guidance and the use, sharing information with the clinical teams, and updates and maintenance. So here are 5 threads of work. Care pathway request and management, knowledge management outside of Epic, so that Pulse search I just referenced, so you're outside of the context of a particular patient. Knowledge management inside of Epic, and then artifact development and implementation and testing. What should that look like? And then outcomes and utilization monitoring. I'm going to turn it over to Catherine to give us the deep dive into knee pain.
So basically, our little proposal double AMC was like 5 master's or PhD projects. Because each of these are a whole body of work. But that makes it kind of fun. So we dove into the knee pain care process because there had already been a significant amount of work done. The orthopods and the community care provider teams had met for several days over lots of time, not even months and months, coming up with a diagram that they wanted to implement in the clinic and wanted to have their guidance translated into decision support. Both of us were very familiar with the work, and also the steering committee approved this as an initial use case. Let's do something that's sort of that is tangible and we can really dig into. So this is the pathway that was developed by the orthopods and the clinical team. You know, they developed a diagram that would show the processes and some of the decisions, and it provides guidance. Does this have, this is the rules that someone would look at in order to determine whether or not to do an x-ray of the patient who's sitting there with knee pain. And then depending on yes or no, you know, you might do, they wanted them to do 4-view x-rays, not 2 and 3-view x-rays, which are normally done. That's what the orthopedist wanted done. If there's not an indication, you do conservative management, and if the symptoms persisted, then you would go on and do the x-ray. And then basically if there's fracture visible, then you go through these steps, and there's some guidance for referrals. Surprisingly, the main point that they wanted to make, which is not very clear from here, is they wanted community clinic outpatient providers to know that x-rays should be done before MRI. Like that was like, it almost should be like a banner in red, like blink, blink, blink. We want you to do x-rays before MRI. That was like their main point. It's not so clear though from looking at this. But anyway, so they, from that, basically that's knowledge that was articulated by the team, and that got translated into creating chief complaints in Epic that should be used to trigger smart sets and BPAs, which are best practice alerts. They added 3 new chief complaints, so when the MA is enrolling somebody, they would go in and have to select knee pain this, knee pain that, or knee pain chronic. They created a smart set associated with this in September 2013. A smart set is a big order set. I'll show you an example. In October, that diagram that I mentioned got put into Intercom, which is now Pulse, and they added links to the URL in Pulse to the smart set and the BPAs that were created. So here's an example of the smart set that was created, and basically the smart set is a huge document sort of a thing that if somebody has knee pain, then they could go in here and the physician would use this to see, here they could click on the links to the diagrams that would pop up. They could also see the guidance that those rules about whether to do an x-ray. And then they'd have sections for, here are the x-rays that we want you to select from, and they're pointing them to the 4 view that they wanted. The Smart Set also has all the different things that one would expect you might be seeing or consults that you might want to order. And it included patient ed materials at the bottom that you could print out, that you could hand to the patient at the time. And so in November 2013, they created best practice alerts, or implemented them, that basically when the physician opens orders and the patient has a chief complaint of knee pain, then they will get a best practice alert that says, oh, by the way, there's a Smart Set that you might want to use, and here's the link to it. And also, if they ordered an MRI without an x-ray during the previous 90 days, then they would get an alert, recommending that they get an x-ray before MRI. And this was released in 3 primary care clinics and 1 orthopedic clinic. And this is the BPA. Just basically, this is oh, by the way, there's a Smart Set you might want to use. Here's the link to the diagram, and here's the Smart Set. If you open it, it'll open. And this is the do an x-ray first. So this is a development and testing process that Teresa, one of our students in this effort, put down on paper, and it was really a guiding document for us through this whole process. That in order to really be complete about development and testing, you need to first, these are stages where you mock up things, you develop artifacts in the build environment, and then you release them. We're sort of doing this retrospectively. This is what we say should be done. But what in fact happened was this got rolled out, and then we went and did an analysis of the assumptions, the usage, and outcomes. And so I'll give you some of the results of that. What we found, we looked at, and this is Paulina's work. Paulina was another student involved in this effort. We looked at first chief complaints. What happens over time with chief complaints? Now, this isn't surprising. These are the chief complaints that used to be there. They turned those off and introduced the new ones that are expected to trigger the BPAs. What happened here? This is when Epic was, the one chart was rolling out, and incidentally, a chief complaint, a generic one, got added to the system, and nobody noticed for about 2.5 months. So this kind of translates that anytime you have a system that's dependent on something, you need to monitor the assumptions, not just the outcome and usage, whatnot. So this shows the clinician's response to the BPAs. The blue is rejecting them, and red is accepting them. And as you can see, that most of these BPAs are getting rejected. So they're canceling all the alerts. Why? So we had to investigate in that further. Who's receiving the BPAs? Well, this might give you some evidence. The gray is somebody, well, first of all, the physicians are in red, and then there's a bunch of other types of providers. The gray is either someone is an MA or they don't have their provider type in the system, which basically means they're an MA. So what's happening is basically the MAs are the ones that are, the patient comes in with a chief complaint of knee pain. They're the ones who are opening up the orders module because the physician may be saying, please order blah, blah, blah for me. They're the ones getting the BPA, and they don't have the independence or autonomy or authority to be able to actually do anything with that BPA, so they're just rejecting it likely. I'm saying that's what. So it's important to understand.
Medical assistants.
Yeah, medical assistants are the ones who are actually receiving these. So it's really important to understand the workflow, how these things are actually implemented, not how you meant for them to be implemented. And so then we thought, well, is this true just for the orthopod clinic? Because they're the ones actually seeing most of the patients with knee pain, and they really work closely with their MIAs, and they're very specialized. But in fact, it's true in all the clinics, the primary care and the orthopedic clinic. So, come on. So then the real bottom line, this is a critical analysis that Paulina did, which is what the goal of the whole big bottom line goal was to get x-rays done before MRIs. So you want 100%. So, and frankly, but what Paulina did was she looked at the patterns during a baseline period the year before we implemented the BPA, or it was implemented, and a year following. So that's the baseline and the intervention. it's a little bit of a misnomer to say intervention because in these clinics, the BPA was not turned on. In these clinics in the primary care, they were. So they really had the intervention. This is in the ortho off, and this is ortho on. So what you can see is in the ortho on clinic, they're the folks who actually designed this and knew what they wanted and whatnot. They went from 87% to 100% of their MRIs were preceded with an X-ray because that's what they know to do. So that's good. In the clinic ortho where they didn't have the BPA, it didn't change practice. In the primary care clinics, none of these are statistically significantly different, but basically it went down. One thing is the red is whether or not the X-ray, when it was done, was actually a 4-view, which was the desired type of X-ray. That did go up, but again, that's not significant or anything. So the bottom line is this BPA had no impact on the primary goal of the BPA. So improvement in ortho, but not in primary settings. So in conclusion, MAs were responding to about 50% of the alerts. BPAs are usually canceled, and there's no statistically significant improvement in the rate of X-ray before MRI in the target settings. So then we said, okay, well, actually what I want to point out, Teresa and I were talking about this morning, what typically happens is during this whole process, there's an expert review that happens when something's getting built. And maybe after something's rolled out, they peek at it and say, yeah, that looks like what I thought. That's the typical development and testing process seen here. What we did was we're proposing to add this phase, and then I'm going to tell you about now is our phase or our process of adding a heuristic checklist and also doing simulation user testing in the clinic of what was actually implemented. And then we're also proposing this. What we did, and thanks to Teresa, she's the one who led this work, we adapted Nielsen's usability heuristics and we created an artifact specific checklist that we could use that actually could be reused as all of these things roll forward. So one of the main contributions that we added to what Nielsen sort of already is proposing is the concept of transparency. It's important that users have trust in the pathway, and it should be supported by transparency and disclosure of relevant information. Basically, this has to do with the DNV, where did this thing come from? Who approved it? When was it last updated? Is the evidence, is the recommendation evidence-based and whatnot? So there's that concept of transparency is actually not included in Nielsen's heuristics, and we think it's important. These are the major headings, so we created a checklist for each of these items. There's about 10 items, sub-items, that basically now someone can go through and in a systematic way look at a artifact, a diagram, a guidance document, blah, 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 and say check, 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 pass, fail, nope. And it may be that not everything has to pass, but at least you can be explicit about what you're not doing. So this is an example of a result from that. One thing that we found was recognition. One thing, and the other thing that is nice about the checklist is we're not only focusing, heuristics usually look at bad things, failure. We also want to point out what works. It's really important. This is sort of a lessons learned from the operational and informatics-y world. You can't just point out things that are bad. You need to really be sensitive about pointing out what works well, which may seem obvious, but we just need to remember that. So when we did the simulation testing and this was the heuristic checklist, it seemed like it was really nice that the Ottawa rules and conservative management were actually called out and spelled out in a simple way. But there was no, sort of citation for that, or where could someone go to get more information? And the transparency issue, what was good was that the clinical rationale was cited and the date of the development and when it was updated was clear on the document. But basically, there was no information on that diagram that said this was developed by the orthopod specialists and approved by the community clinic, blah, blah, on this date, so that others know to even think of it as a valid thing. So we did simulation user testing in 2 sites. Well, this is recommendations. What we did was in 2 sites. You should have more than 2 users per site. You want to capture a variety of roles, and basically in this kind of a method you want to basically saturate your findings. Find as much as you can in one setting, move on to another, and as you start finding the same thing over and over again, then it may be time to be done. But it's important to have a breadth of input. So one thing that was fun about this was we got everybody access to the Epic Playground. We did testing in there. We went to the clinic, presented a scenario of a patient with knee pain and worked with the clinician had a very structured script, went through a patient, they wrote an order for the patient, and while they were doing that process and started getting BPAs and whatnot, we did a think aloud procedure to capture what was going on and also did a structured interview. Some of the fun findings we found were they were surprised to see a BPA related to knee pain, and they sort of assumed they were all related to health maintenance, which is surprising. One thing that they said is, I never deal with health maintenance or something like this when I'm dealing with writing orders. So it was amazing to watch them. They'd be going through and they would click the cancel alerts. And I said, did you even realize you just canceled the alert? And they're like, no, they are like subconsciously canceling the alert things when they pop up in front of them. And then they also said they get skeptical of links because I worry about it interrupting what I'm doing and it may make me feel trapped. Basically, when they have a URL and they're supposed to go somewhere else, they get another window that pops up and takes over where they are, and they're not sure where they are. I mean, the screen is very confusing already in Epic. Lots of info. One thing that was really fascinating was this is that smart set, and remember this was at the top of it. People were thinking when we designed the smart set, you can default it to be closed or open. If this were open, you'd see those lists of x-rays that they had an option to do. But everybody said, well, let's close it as a default so that they don't see all this clutter. Well, then what the physicians thought, so this is what they're presented with, they thought this 0 to 4 selected meant that 0 to 4 of the criteria had been selected. Like they thought that it meant something. And all it meant was that they hadn't selected any one of the 4 x-ray options that's in there. So these are clinicians who are medical director of the clinic who's very involved with these using Epic all the time. And so the functionality is not intuitive to everybody. They have their things that they see all the time and don't always understand functionality that maybe the Epic team would think that they would. So what we found, which was fascinating, was that we identified 17, after doing this whole process of the 2 different methods, we identified 25 different major heuristic, well not major, but heuristic violations that really need to be addressed. So minor, major. 17 of them, 2/3 of them were found just by doing our usability evaluation, which is pretty inexpensive, efficient, quick way to find things that need to be fixed and could be fixed before you ever engage a physician who's more expensive and you're pulling them away from their clinic time. The other thing that we noted, and that's what we noted when we did the second testing in the simulation, we found the same 15 issues that we could have corrected and just been done with. We found 8 additional. So this tells me that we need to do both. You need to do both, but you also could get a long way before you ever engage clinicians. So Heuristic Checklist is inexpensive and a fast way to identify and correct problems early, and user studies are needed in addition to the heuristic. So based on this, we've recommended to change the first BPA to just a passive strategy, and there's some options that we're looking at with the Epic team, and basically updating the second BPA to follow some more standard conventions of the wording and whatnot, but basically leave that one as a active BPA, because people did want that one and they thought that was actually useful information. So based on that use case and deep dive into the knee pain, we started working on these 5 threads, or in simultaneous we were working on these 5 threads of work. So Sandi led this effort. Everybody had their chunk.
we all had a piece. Too. Thanks. So I've mentioned this already, no standard process for requesting or approving or maintaining the pathways. Multiple entry points that all landed on one person's desk. I won't use her name, but she's terrific. She's an IT professional. She's trying to help the providers to the best of her abilities, but she had no support structure behind her. Is it the right clinical guidance? She's an IT professional, not a clinician. Who approved it? Is there conflicting or divergent guidance somewhere else within the organization, or is this a system approach? She didn't know, so we needed a process. We need a process, not a person. So we just visualized this very quickly. This is a high-level diagram. We want a curated site in Pulse to maintain these documents that can be exposed within Epic. The preliminary design of the Pulse site is complete, and it will include an approval mechanism. A request mechanism. Then there'll be a little bit of formatting and things like that, if need be. Take it to steering committee review. Now, steering committee has not been identified yet. I am in the process of proposing 3 options to our Chief Medical Quality Officer, and we will have a steering committee for these pieces of work. Approved or not, we had to have a feedback loop back to the user if the steering committee needed more information, publishing it, submit for inclusion in Epic, which will include going to EHR Ops to make sure that all of the IT world agrees with this, and then it enters a maintenance phase, which will allow us to review these once a year. It's based on the same criteria as our policies. So say I'm the owner and Catherine's the liaison of a care process. I will get notifications 6 months and 3 months out, and we were debating what's the right time frame. We'll kind of clue into that once we get our steering committee. But we need to give people time to react to that. You can't tell them a week before it's due because they might have to do a lot of work. If the guideline has changed significantly, there's work to do. So that feedback loop will happen automatically. It'll trigger automatically, and then it'll come to a work list for my value program coordinator to make sure it gets done. This is the site in Pulse. This is very drafty draft, as I like to call it. There's a lot of work to be done, but we're going to be asking the requester to fill in a lot of information. That won't be an email stuck in one person's email in basket that may or may not have all the appropriate information to get it online. So determining the approval body, I mentioned EHR Ops is the IT world, but we need a clinical approval body. Leverage this process across existing pathways as well as for our top 50 medical conditions. Standardize the format for visualizing. We have, there's 12 different, if we have 12 pathways, there's 12 different ways to visualize this. We kind of need people to know what to expect when they open a care pathway. And then standardizing the metadata within Pulse. So if we have fields that must be filled out, we will capture that data. And then include the process for the owner to recommend terms, because we want this to be searchable and indexable in InfoButton, which will come in a minute. This is the last juggling act.
Okay, so now we have stuff put in Pulse, which before used to be linked to a link in Epic, and there's like this random, there's an asthma thing here and a bloody-blah there, and it was just links in different places. So now everything's going to be in Pulse, but how do you get stuff out of Pulse? So right now, the current state is you're in Epic, and you, InfoButton has been implemented in Epic, where if somebody wants to get information about a medication or a diagnosis, they can click on the InfoButton link, and they can get context-specific information about the particular medication or disease or whatever from external resources like UpToDate and PubMed, and that's fabulous. But if somebody wants to get the information out of Pulse, which is really what we want people to be using here, or at least know that it's there. They have to basically go out, go to Pulse, and look for this stuff. So they're separate. And right now, if you clicked on asthma, you get kind of this stuff, and you have no idea, what. It's like a big, big file cabinet. It is a big file cabinet. So Pulse contains both clinical and non-clinical materials from the entire organization. Search results often find irrelevant stuff. Info button in Epic only accesses non-UUHC materials. So the materials in info button are you can only use info button to access stuff if you're in a particular patient's record, and that particular patient has that diagnosis already. That'll give you the info button little icon. And providers, when we did our user testing, they said, I just want to have one place to go where I know I can find the stuff that I need. So the key user requirements that we identified were that users want one place to search for UUHC, point-of-care pathways, references, calculators, and they want the ability to search outside the context of a specific patient. They want to be able to say, do we have something about knee pain that I should know about, because I either am about to see a patient or I saw a patient. So the desired state is that within Epic, they'd be able to get context-specific or all resources that they care about from both external and internal resources. And they want not everything from Pulse. We want to control what they get from Pulse to be the things that UUHC has approved and defined to be what should be pushed forward at the point of care. So Melinda is Jacob's wife. So Jacob led this effort, Jacob Wan, who's not here, but he named his prototype Melinda. It's very cute. And so what he's done is, I'll go to this. Developed a way, he's leveraged the info button technology where we've indexed Pulse resources using the info button manager. Let me just, before I do that, he's taken the resources that are in Pulse, and there's the info button manager kind of sits out here where we index the things that are in Pulse that should be findable from a search engine, i.e. info button. And so then from his web page, he can put in a search term, and he's put in an autocomplete that makes it kind of handy. After you find some, you click on that and it brings up, well, you don't even have to click on anything. You put this in here, it autocompletes. It starts a list of potential resources. Right now, this is primarily the things that are just within UUHC, but he's put a little icon if it's internal to UUHC. And it also has a link to the document. If you click on this, then it brings up something that I'll show you on the next page. But what it does is it allows you to get the integrated view from all the resources that are actually available through InfoButton plus the UUHC ones. So if you were to click on this search over here, then you bring up the InfoButton UI, and basically what you get is, say you were to say asthma, you would get the, this is a resource at the VA that is actually openly available. One problem that we've discovered is that within Pulse there's the security issues and iframe issues with InfoButton that make it so that it's not a one-step process. But this is how it's supposed to work and how it does work at the VA. If something is publicly available and we index it that way, you would click on that and basically it would pop up here, and then you'd have your little workspace where you see what we want you to see from a UUHC perspective, plus you can also access all the other resources. And the nice thing about the InfoButton UI is that this list of things over here is only populated if there are things that are available. So if you were to, theoretically, you put, I don't know, conjunctivitis or something. If we don't have anything indexed at UUHC that's relevant to conjunctivitis, then you won't see the UUHC thing here. You'll just see whatever it is that is indexed. So that's I just think that's really handy. So the strengths of what he's done is have a relative responsive UI. The resources indexed by InfoButton can now be accessed. Actually, he made it from any device, just from a mobile, he's so clever. The limitations right now is he doesn't have a free text search, lack of security to control access, and the prototype right now has limited features, but it's you could imagine there's a lot of things that could be enhanced. The next steps would be to index more content, in Pulse, to perform usability study to inform the enhancements of the info button UI, because actually we're finding some issues, but there are things that would be feasible to fix, but don't just do it. Like, we've already shown that it's important to do usability testing. And then if it were to be, actually implemented for real use for the system, we'd want to think about security, and where to implement it, and formalize the development of Melinda. Right now it's Jacob's, garage project. That's what he said today. So, but he would love to get a PhD, and I think this would be a great effort for him. Also to do, to include an, features so that you can monitor user interaction. So then we're on to the inside Epic. So now you've got all the knowledge sitting out there, and then you want to operationalize it, and so you're going to create BPAs and smart sets. And this is why we were falling off the cliff, when we just could not even think about how you have to start chunking this out. So inside Epic, we are, I'm just going to be brief, that the current state is really, this is kind of fundamental, is an increased awareness that we need to manage stuff outside Epic, not inside Epic. Stop creating specific links within Epic for every guidance document that somebody emails to the person in Epic and says, put this on there. And so things need to be managed in a systematic way, and then accessed from within Epic. Care pathways and guidance, there needs to be a new strategy based on, we're doing some analysis of how to phrase things in the BPAs, and how to, and also what these pathway documents should look like. Teresa's doing a first pass on, we've got 3 different logical options. Intermountain, University of Washington, University of Wisconsin had a nice, and then South Carolina, and then ours, and doing our heuristic checklist and sort of coming up with the recommendations on a standard view of how we standardize our guidance documents. And then BPAs need to be standardized and monitored. Right now, there's really no monitoring going on with the BPAs. The future state is that care pathways will be managed in Pulse and accessed from within Epic, and BPAs will be standardized based on classification. So the current situation with this is we need a standardized process for developing alerts, order sets, and diagrams, and need user testing performed before and after deployment. Like we said, we really believe that this should be implemented, that anytime a new process is being implemented and you're creating artifacts and whatnot, you need to, during these different phases, you need to systematically address these, or if you're not addressing one of them, then you need to basically make that decision. And this one is the one that I think is really important, that gets left off a lot of times. We would recommend basically refining our user testing methods that we had, and basically doing some of that for the things that already exist and the things that are rolling forward. And we would apply that to another use case, learn from that, and then my goal would be that something would sit on the shelf, that whenever they're wanting to implement something, they pull it off the shelf, they do the testing, they learn from that, and then they roll on. Like right now it's very haphazard. And finally, outcomes and utilization monitoring. Currently, there is a data mart to monitor alerts that's being tested for the sepsis care redesign. We would recommend that continue and be enhanced, but also that chief complaints, when they get created, they should be a standard way of creating chief complaints. Like right now, to be honest with you, those chief complaints that were implemented and developed for the knee pain project are, I don't even remember exactly what they were, acute knee pain, traumatic something. It's like, really, we should go back, we never even got to this, but someone should go back to the MAs and see if at that point in the time when they're assessing that patient, do they really have first of all, the knowledge or even the ability, it's not because they're not smart, I'm saying that at that point in time, has the information been shared yet where they could actually decide which of those 3 chief complaints need to be selected? I'll make a bet that they're just sort of, there's a lot of ambiguity there. It's not specific. I'm not using the right word, but anyway. So we also should create, when you have chief complaints that are driving a process, then that monitoring of that needs to be included in the scorecard that Sandi talked about way at the beginning. And basically, we need to do ongoing monitoring. With respect to BPAs, we need to standardize the format and functionality. And we need to limit the clutter that's in the BPAs. Basically, right now, there's an acknowledgement box in all the BPAs, or many of them, that says, tell me why you're not using this. And frankly, that's basically doing a user study. And and the physicians were saying, I don't know why, I'm afraid to put something in here because I don't know who's using this information or where it goes. You know, frankly, if they put something in there, they accept the BPA and it goes into the thin air. It never like reappears in any report that they see, or so there's no purpose in putting text in there if it doesn't add value to what they're trying to do. And also it'd be useful if they acknowledge a reason. It'd be nice if it said, I will cancel the MRI, if when they click that button it actually canceled the MRI, which it didn't. And then also we would recommend unselecting all the open smart set defaults, because right now one of the reasons why they don't accept the BPAs is because if they do accept them, first of all, what happens is they get in there, they get a BPA. They get not just the BPA for knee pain, they get the BPA for the mammogram, for this, blah, blah, blah. Every BPA that they're eligible for comes up in a big section, and they can't accept them individually. They have to accept all or none. And if they accept all, then what happens is any of those defaults that are in there get populated. And so all of a sudden, they have a set of orders that's 100 miles long that has lots of things checked. And so that's one reason why we've trained them to cancel all BPAs. So we're also recommending outcomes monitoring. And I'm going to click to next steps. I want to, in the last 5 minutes, I guess I'd like to acknowledge the students that have been part of this. Teresa, Jacob, Stacy, Damian is not a student, but Brett, Paulina, and Mike Adair. Mike and Jacob are getting their masters from all this. So we had a couple lessons learned. One is that, do you want to come up here with me? So one of the, is that projects for collaboration across the health system, need to be meaningful both to care delivery, so to the Sandys of the world, but also for the academic and the research mission. You always have such passion about this next time.
So I'll say this very briefly. I have been given students to work with in the past, not from BMI, but from other departments, and they're just kind of given to us without support from the department to help guide the students. Well, I'm an expert in process improvement, and I've worked in that field a long time, but I'm not an expert in what these students were studying, so I can't give them that kind of guidance that Catherine could give these students. So the practicum required my engagement and Catherine's full engagement in guiding the students to do this really amazing work. And they did amazing work that we couldn't have gotten done on the operations side alone. So it's been this tremendous partnership. What's next? The students said, and I've got my director hat on, not my student hat right now. It provided a space for the students to explore, and professionals who do this, but they're getting their master's degree or PhD, to jump in and take advantage of opportunities, to leap ahead and explore and innovate in a safe way. Real world exposure, I think sitting in those steering committee meetings and presenting is valuable to the students. They see the barriers that come up in real world situations. And I think that's really important for our student population. If they haven't been, if they aren't already professionals. And bridge research and operational gap and tap into existing resources. So the way that Jacob has leveraged Info Button is unique, and he had a safe space to do that. And it was fun. It was fun for me, it was fun for Catherine, it was fun for the students, and we have to figure out a way to do this more frequently. Thanks to our steering committee and the students, and Damian and Guilherme, who came to the rescue in a number of situations. We appreciate that. And thank you for listening. And we have a few minutes for questions if anybody has any questions about the work.
Any questions?
How did the orthopeds respond to the
Well, and they did. They thought it was all solved for the primary care physicians. Those people ought to fix that. And at the end of the day, the people that were the physicians that were the most engaged with this process were the primary care providers, because they're the ones that are leveraging the guidance. The orthopedic surgeons and providers know this stuff, and as you can see, they went to 100%. They know they need to get 4-view x-rays. The primary care physicians are not seeing that many, and so to do the right thing, they were most interested in what we found.
I guess to follow that up, though, we need to feed this. We presented earlier data that actually showed that there was an improvement, and then when we reanalyzed it and kind of looked closer, we realized that there isn't an improvement. And to be honest with you, we haven't shared that with them yet. But I also feel like they've moved on to, and it's really interesting. It's it's just sort of the reality in working in this world. You have to give information back really quick. I mean, this was 2003 when they, 13, not 2003. Yeah, I wasn't even, no, but, so this is, actually, we need to, this stuff is all like in the last month that we've reanalyzed, and, so we need to share this back with them. But, they're frankly sort of off the radar. I don't think they even, this was all all the top 50 stuff, so the world has moved on. But everything that we did for this informs the next thing.
It will be very helpful as we consider the top 50 medical conditions. And that's work that's going to be ongoing. Those medical conditions will shift. And we really did a great job, I think, of laying the groundwork for that work.
So follow-up, how will this move forward in operations?
So we first have to get a steering committee. I am proposing that. I should have that done in the next week or so. And then we have to present that to HCEC, which is the Healthcare Delivery Executive Council. And then we just plot along. My engineering team will have the checklists, because they're the ones developing with the clinical teams, the care pathways. And that's a really good place to start. And they can do those checklists with their provider teams. I didn't do that in time for the sepsis team, but I'm going to ask them to go back and do that. And that's been a very successful project, so if we can make it even better, that's terrific.
So I think that, I mean, we presented this to the CDS committee the other day. We didn't have a lot of time, but folks seemed really interested. Carrie's very interested in getting our feedback and recommendations about the standardization. I feel like there's a hole. There's the whole usability. There isn't that dedicated effort. I mean, there is a hole there in terms of who can actually lead the. What Teresa has defined is a job role that is basically. I know that you're saying that you could implement the checklist, but I think it requires someone with real usability training that can follow that through, and that, frankly, does not exist. So somebody needs to. I would propose that expertise needs to be formalized.
I agree with that, but we need someone to own this process, and we don't quite have that yet. And so that's where the resources will be allocated. So first step, getting the committee, And second step is, here are gaps. We can patch some things together using the checklist, but at the end of the day, we need potentially a resource for this, or two, or more.
I think the biggest issue with all of these resources.
Yep.
When you have build requests from 6 months ago, but I'm getting emails from it's very hard to then say, we're going to just not build it, we're going to go afterwards and build it.
Right.
I think what I would see is, I think that what Jacob has done with the enhancing info button and his Melinda functionality that should be like an effort, like a real project. And I don't know if that becomes part of, Dami and I were talking about this, could that be part of what the the EPIC optimization team would take on, or does our department want to take on? That's something that I feel like that there's a beginning and end there where we have the expertise, and that's a great effort that needs to be defined, and somebody needs to take the lead. It's not going to be me. It's going to be, but that's like, so I think there's the need for the usability, that whole piece, and then the info button access outside EPIC. The other stuff, I think we make recommendations, and it just ho-hums along how it does. Well, and then Sandy's doing all the effort of formalizing the request and monitoring of the document control kind of side of things.
And I will say, until recently, until we started down this path of standardization and systemness, which is relatively new for us, that there wasn't the will to make those changes, and I think there is now. And I think there's receptivity, so. Thank you all.
So thank you.
We went over, sorry.
Thank you, that was really good. Hopefully that's not being recorded here.
No, I just turned off the mic. Oh, maybe.